All right. Hey, everyone. Welcome to the next episode of Virtual Global Spine. For those of you that don't know me, I'm Jonathan Rasouli. I'm one of the hosts here in the Virtual Global Spine Conference. I've been here for about 4 years. It's been a long time. So tonight I'm going to be presenting a little bit about a topic that's near and dear to my heart. That's robotic spinal surgery. Give you some updates on some new things that have happened, and talk a little bit about why I got interested in this in the first place, why I got interested in this technology. So, for all purposes, I'm going to primarily focus on the two main robots that are out there. There are a couple more coming out down the pipeline right now, and but the two main robots by all purposes is going to be the Medtronic Mazer and the Globus Nuva Excelsius. Those are like the two. They probably dominate about 80 to 90% of the market share right now. So, and when people think of like using the robot, we're usually thinking of Mazer or Excelsius GPS, and it really just depends on the center. Sometimes some places have both, and there are some nuances in terms of the differences between them, but for all purposes, these are primarily used in the context of putting in pedicle screws. There are other uses for them, which I'll talk a little bit about, but that's the main use is putting in instrumentation during a case. So, like, in terms of the uh, placement of instrumentation, so pedicle screws, right? So I'm showing a little video of freehand pedicle screw placement and how we used to do this, or how I still do this when I'm doing, let's say, a T-lift, for example. So, I have my scrub deck here, my assistant across from me. I'm using an osteotome and a mallet to create an inferior fascicectomy. Then you can see that she takes the Lexel rongeur, completes the fascicectomy there. I'm doing a little bit as well too, right? Let's just fast forward that a little bit. And you can see there's a lot of back and forth, passing the instruments. Um, my scrub tech is obviously waiting for the next step over there. So once we have that, obviously you feel with the pedicle sound, you feel the channel, make sure there are no breaches. And then with a tap, if I'm putting a 6.5 millimeter screw, there I use the gear shift to create a tract. I'm using now the pedicle sound to feel it. He passes me the tap, and that's going to create, if I'm putting a 6.5 millimeter screw, I usually use a 5.5 millimeter tap. I mean, we all know this. For those that instrument regularly, this is pretty standard stuff. So you can see just a lot of motion here, a lot of back and forth. I feel the pedicle sound, right? Everything feels good. Then last but not least, the screw, right? Okay. Lots of motion. And you repeat this every single screw, every single screw. That's just one screw I put in, right? And that's pretty fast. It's pretty good. Now you can do it with a power instrument, put that in with the drill. That has its risks and benefits as well too. But this is just kind of showing you just kind of a standard, freehand way of doing it. That was pretty quick, right? Okay, great. So now when you introduce a robot, this process is a lot more streamlined. I didn't use navigation in the other picture, right? So here you can see you have the robotic arm. It brings you to the spot that you want to put the screw in. You bring a drill. It's all power, by the way, right? And look at the screen, okay? So you can see it tells you where that screw is supposed to go, the depth of your drill, okay? You have a drill guide that goes down. This is assuming you're doing this, either percutaneous or open. And then with power instruments, you can see how you put the screw in. And you can look, you see it shows you on both views, both axial and sagittal. You know the screw depth, you know where it's going. Theoretically, it's going in the right spot. But everything it's much cleaner. It's not as much motion, not as much movement on the patient body, easier on the surgeon. You can see it's elegant in a way, like in terms of putting instrumentation. So when I first saw this, and I first kind of played around with this in residency, um, kind of played around with robots. I was pretty amazed. I was like, and mind you, I had not seen it in action. Usually, you have a model like this, so they bring outside the OR or they bring it to a conference or something, and you're like playing around with this, and you're like, wow, like I need this right away. It's the greatest thing ever. But and this I would say this kind of set in motion my interest in robotics and kind of minimally invasive spine surgery because before then I was very interested in deformity and this, the open kind of old school freehand way of doing it. Now, it wasn't until I actually finished and I was in fellowship and as an attending where I actually got to use the robot that my opinion of it has changed a bit as you're gonna see. So, the thing that's nice about the robot is that it's this nice kind of balance between the hardware that you use and the software that guides it and drives it, right? And for the Mazer, and also the Excelsior's GPS, the vast majority of the advances have not so much been in the robotic arm. That's been pretty constant, right? It's been more about the software. The software is much better. It's much more user friendly now. It's much easier to use. This used to be very aggravating in terms of like getting everything set up and having your trajectories and your screw paths and your plans. This used to be very, very difficult to do. Now it's super easy. It's pretty much all automated now. The computer has the ability to come up with this plan pretty much by itself. It used to be your rep would do this before the case and tell you, okay, Dr. Rasouli, all right, I looked at this and I planned out using a 6.5 by 30 millimeter screw here and a 6.5 by 35 millimeter screw here. And it shows you kind of like where you're going to go. And what's nice about this as well is that you can see in advance what your surgery is going to be, what you're going to end up with at the end of the day. So you have like basically you're going to go mid-thoracic down to ilium, right, with the S2AI screw. You can look at different views. You can say, oh yeah, you know what, I don't really like the kyphosis here. I want to bend the rod out a little bit more. I want to change the screw. I don't like this, which is pretty nice. Now, one of the things I will say, having done this a couple of times, right? Here you go. So this is just kind of showing you what the software looks like when you're planning out placing some screws. And this goes segmentally, every single level. You can plan this out. And you can look at this in every view. It's nice. Does it add any more information? Not really. Does it make the case any easier or better or faster? Not really, right? I mean, all the stuff we were doing with freehand, arguably this is slower, right? Um, is it useful? Yeah, I'd say mildly, right? I've already, before I've gone into the OR, right? I've already have in mind what the plan is going to be. I already know I'm going to do an L45 TLIF, right? Do I really care if the screw is 6.5 by 50 versus 6.5 by 45? Not really, right? Um, that's not drastically anything different. Another thing that I found out was interesting was you can see also the screw trajectories here, right? Maybe this one is a little bit medial. Maybe I want to come a little bit more lateral for this, you know? There's certain, and that's more in my head, it's when you're actually there in surgery, you kind of look at what you've got and you're like, okay, yeah, I'm actually come a little bit more lateral on this one, or I'm going to come a little more medial because something happened they didn't expect, right? When that's the case, um, when that's the case, you don't really get that in with the robot. You have to, everything's kind of pre-planned in advance, and if there's something that shifts or something that moves, um, it can really throw you off. Going back to power, by the way, right? Let me show you this one more time. So I used to love this, by the way. I used to love using power instruments. I thought it was so nice, so easy. Um, I liked, it was just easier on your wrist. The elegance of putting in a screw or using the tap and a screw under power. It was really nice, right? Problem with this is that if you have a kind of a bigger patient or your exposure is not great, you could end up moving the patient on the table when you put that power instrument in, when you sink that screw in, or if you go a little bit too deep, right? Um, you don't want to bury the screw head, right? You want it to be a little bit proud. So sometimes if you have, let's say, somebody who is new and is just using power for the first time, the tendency is just want to bury that. So, and what can happen is the patient can move on the bed. And if the patient moves on the bed, now your nav is off. And it just one little thing like that messes up your whole day. And it's amazing how easily the navigation gets thrown off during these cases and becomes inaccurate. Uh, it's shocking how inaccurate navigation is and how you have to be really, really at every second look at it like, does this make sense? And is this what I'm seeing here make sense on the computer? Because it's so easy for that nav to get inaccurate, and you can really do some bad things if you're dependent on navigation. The robot's fun. It's a nice little instrument, but it does not supplant freehand pedicle screw placement in any way whatsoever. So back in the day when we would put in stuff under fluoro, this was like the most advanced thing. Oh wow, MIS, and I remember when MIS was basically bringing would be the concept of MIS was doing bringing up fluoro and doing like stab incisions and putting these screws under fluoro under a K wire, and that was considered to be MIS instrumentation. It could still be considered MIS instrumentation, right? But the thing was, you could never get a good image. Everything seemed washed out. Everything seemed hard to get. Like in the best case scenario, like when we were in a cadaver lab, it looked great. But then when you actually be there in the OR and a patient was, for larger, it was very hard to see stuff. And you can see this is just standard, like if you're going transpedicular here, this is where you're aiming for. You aim for the pedicle, you look in the sagittal view, AP lateral, and you kind of get your Jamstone needle, your K wire, and you just kind of keep moving. Now, what's nice about the robot is that it really streamlines. When the robot is working well, it really streamlines that process quite nicely. So you can do the same surgery much easier under the ideal conditions and when everything's working the way you expect it to. Now, just to give you an idea, you can see here on the left-hand side, you have, this is the perfect AP and lateral view. But if you look at it like under real world conditions, when you're with a tech who doesn't know what to do and the patient's obese and everything seems washed out, it can be, look, how are you going to comfortably put in screws in this scenario? It's very, very difficult, right? I mean, you can kind of, in your mind, picture it a little bit better, but it's very tough. And what I liked, when I was faced with this situation, um, in real world practice, I never had this problem with the robot, which I liked. I never had the issue of this kind of, you'd see this, you're like, all right, what are we gonna do? Do we cancel the case? Do we keep moving? I mean, what can we do? It's not an easy call to make. Because now if you cancel a case, you got to explain this to the patient, why you canceled, to talk to the family, reschedule them. It's a whole thing. It's not easy to do that. It's not like you just snap your fingers and the patient will be okay with that. You may lose the patient. They may not ever come back, right? All right, so coming here, the robot is able to generate essentially almost like, it almost uses almost like an AI. Let's put it that way. It's able to generate an ideal, even if the fluoro is bad and you don't have a great image, it kind of can figure out where things should go and what things should look like. And it's pretty accurate. It's pretty accurate. Much more accurate than you would expect. And when you have a patient who you're doing like a big surgery on, if you're left in that situation, unfortunately, it's a very large patient with obviously a very big pannus. When you have these kind of, very large body habitus, they can obviously develop wound problems, right? What's the issue with this is that, it can be tough. It can be tough. And what the robot enables us to do in a good way, and I like this a lot. This was a good illustrative example of a patient who had, a tattoo and was very, very keen on keeping this tattoo intact. Normally, we'd have to make a big midline incision, go right through that heart on the tattoo, but here we were able to get a fairly nice cosmetic result by going around the edges of the tattoo. This, obviously you can do this with fluoro too. It's not like a robot only allows you to do that, but what's nice about this is whereas I would always think about a midline big incision, which I did most of my residency, now I was able to kind of unlock almost like a tool that could help me be a little bit more flexible in terms of how I was going to do these surgeries. Is it absolutely necessary? No. Is it nice to have though and use in the right situation? Yes. So when I was in my fellowship, I was able to use this more and use it in a setting of deformity because most of the time when we were using robots, it was pretty new technology, and we were looking at doing like an MIS TLEF, for example, and everything was MIS. Okay, we're gonna use a robot to MIS TLEF, use a robot to SI fusion, use the robot to do bring the tube down and do an MIS decompression. That's usually what we would use it for, or put in screws MIS. Here we were actually able to use the robot in a way that was more kind of a classical deformity case. You had this patient who had a pseudoarthrosis. They had unilateral fixation to the pelvis and also developed PJK. So we're able to use a robot here. And this was nice. This is kind of illustrated where the planning software is kind of helpful, where you have your plan in mind of what you want to do. it can be hard to explain at times to the staff and to your reps. Here you're able to actually show it. You're like, okay, look, we're going to extend this patient down to the pelvis. We're going to put bilateral pelvic fixation. We're going to extend them proximally to, let's say, T4 or something, whatever. And you can show this and you can plan out, okay, what size rod we're going to use. Are we going to link up to the old construct? Are we going to replace the rod? These are all things that you can do in advance. It's nice because you go into the OR with a pretty clear plan in mind. You're not thinking on the fly, but again, things change and you often do end up having to do things on the fly, and then like all that planning you had is kind of out the window. How many times have I gotten custom pre-bent rods, and then when I go to theoretically put that rod in there, it doesn't even fit, and I got to bend it out again and cut it, and so it's things can be even in the best case situation not really what you expect. So this is showing you again how nice the software is to kind of plan out what you want to do, especially with if you're putting bilateral pelvic fixation, or I say, I'm sorry, but yes, bilateral pelvic fixation, but 2 pelvic screws on one side. So this patient's getting 4 iliac screws, right? Here is where either navigation or the software of the robot is very helpful, because these can be hard to plan and do freehand without using an X-ray. So I think we got a pretty nice result at the end. We were able to really correct this patient's proximal junctional kyphosis, get better fixation distally in the pelvis. So this was a nice use of the robot here. It's the software. The software was very, very nice. As these patients get more complicated, as we're seeing more and more revision cases, I mean, it's endless how many revision cases you can do. The robot really helps. It really definitely cuts down time. It as you cut down time for like your plan of what you're going to do. And it can, when things are running smoothly, you can also cut down the time in surgery as well too. Now that being said, when you first start, you're probably gonna add about 2.5 hours to your case minimum. So let's say if it takes you about 2 hours to do a 1-level TLIF, add another 2.5 hours with the robot, because it's not just the setup and the registration and confirming the accuracy of the robot, but you also need to have all the trays there. They need to set up everything. They need to make sure everything's set up. These things take a lot of time. And unless you are using robot every single case, that's the problem with this, by the way. Like, you can have this robot and you're like, okay, I'm only going to use this for the big cases, right? Then you're not really, unless you're doing big cases all the time and using this robot all the time, then the staff doesn't get comfortable using it, and then like it can be difficult to get these cases going well. Also, these need to be the first start case. Like, if you have, like, let's say you want to do this and you do something else, you don't want to do that robotic case with the team that has never even seen this thing. The 4 p.m. team. You don't want that team there. You want the best team. So you have to kind of plan your day around this. And that can be tricky. So going into this, we planned out putting a kickstand rod here for this patient who got a T10 pelvis. This was actually nice to do because we were able to, with the kickstand rod technique, there's a very specific trajectory of that iliac screw, right? It has to be kind of like almost vertical, right? Because what are you doing? Here looking back on it, we really didn't need to do a kickstand rod, but what you're doing with the kickstand rod, right? You're trying to align the hips. So if the crest is something like this, right? You want to push this one down. So that's how you want that vector of force to be going down to that hip. So that can be tricky. It can be hard to put that screw in. It can get loose, can perforate anterior posteriorly, and you don't get good fixation and it doesn't do anything. So or can break later on. So if you want to put a good kickstand rod screw in, this actually helps a lot to plan this out in advance and kind of know where you're going to put this, because you can't just put that in anywhere. And as patient gets sicker and more unhealthy and worse and worse and worse scoliosis, it's helpful to do this, because you can do this with the MIS technique, and you don't have to worry about tissue handling and all these problems this patient had. We're able to get a pretty nice fixation here, and then this patient ended up getting a tattoo on their back that kind of hit it. One of my colleagues actually started using this for pediatric deformity, which I thought was pretty cool, because I'd never seen the use of the robot in this sense. And where I thought this was pretty nice this patient with a primary thoracic curve, fairly rigid. We were able to plan out in advance where we're going to put the screws in. And as you can see, this is kind of show you some of the software, but you can see we actually were able to kind of predict what correction we were going to get. So if you look on the left screen, right, this was, if you just ignore all those complicated angles, right, just look at what the shape of the curve is, right, look at that. And then if you look at this, they were saying, okay, if we instrument, doing this, this kind of instrumentation, the surgery, we will get this correction from this patient, right? And if you look, this is what it predicted we would get here, right? And that's pretty good, right? I like that a lot. I thought it was I'd never seen that before. I was very surprised by that. I thought it was pretty interesting. Um, so when I saw that and we ended up doing the surgery, right? You can see here it's pretty nice, pretty accurate, I gotta say. And we didn't we didn't have to do anything crazy here. We just did posterior column osteotomies the whole way. We didn't have to do any anterior column work. We didn't have to do a VCR, anything like that. It was very, very straightforward case. And you can see it actually was pretty accurate, right? If you look at what we started off with, what it predicted, and what we got, it's pretty nice. I like that a lot. I thought that was pretty interesting. And this is just one illustrative example, obviously the best illustrative example I could find. But I found that this kind of held true throughout most of the cases that we did. So I like this a lot in the setting of pediatric deformity. Now, obviously, you've seen this ad nauseum at this point, with the benefits of MIS surgery, right? And I'm definitely, I believe it has its, I don't want to get in a debate of MIS versus open because, I'm obviously on the side of open. That's my personal preference, um, there are definite advantages to MIS surgery. Now, the pendulum has swung kind of back and forth, and where we're at now is kind of that happy medium of, certain surgeries that we're doing open, pretty standard, like a T10 pelvis with an osteotomy, like a PSO, for example, that's open, I think 99% of the time, right? A TLIF, I like to do it open. Some people probably do it MIS, you can, but I say like pretty much most of the fusions greater than 3 or 4 levels are generally, I think, done pretty open from what I've seen. Revisions mostly open. Alex, I see you there. I'm wondering, maybe you want to chime in, like what with robot. I know you've been a adopter of this. I'm just wondering, like when you first started and using robot and MIS, where are you now, like percentage wise? What percentage are you like traditional open? What percentage are you kind of MIS still?
So, hello, Jonathan. Nice talk. I appreciate your insights. So, I haven't started with robotics yet. It will be the first project in 25. I am coming from an open era, and
Right,
I do some MIS, but I think the percentage is more the question not open or MIS. It's more lateral anterior indirect decompression. So we have several tendencies right now. They're
right.
not competing. They're not competing, but I think you will get a mix. Your question is brilliant, asking for a percentage. How is it? I think it's like in my hospital, it's like 20% MIS. It's 30, 40% indirect decompression with laterals and
And it's
A-lifts,
lateral.
and still it's 40% open.
Yeah,
The
it's still
majority is
open.
still
There,
open.
yeah, yeah. That's interesting. That's a lot. That's interesting. That's I would say we're probably like 70% traditional open, 20% MIS, and 10% A-lift lateral. And that just has to do with, I think it just has to do with approach surgeons, and I think it has to do with comfort level of laterals. When I first started, I did very few, and now I do a lot. I do a lot of laterals. I have at least a handful a month, I'd say. I don't think a month goes by where I don't do at least 1 or 2 laterals, right? Whereas when I first started, it would be like 1 or 2 a year, and now I do probably 1 or 2 a month. So that's a big change for my practice. A-lifts, I love A-lifts. I do a lot of them as well too. So I would probably say I'm more in the indirect. I become more indirect, which is interesting. Um, but if I have to, I'll my go-to if push comes to shove is a TLIF. I would say like that's generally my gold standard is just is a TLIF versus lateral or ALIF. I will default to a TLIF, which is I'm trying to change that. I want to change that to indirect, but kind of old habits die hard, I guess. um, I just want to, I unfortunately have to have a little bit of a short talk tonight. But what I'm trying to drill home is that how nice this is in the setting in the context of the planning and the software, which is really nice. And this keeps evolving and adapting and growing better and better and better and better. And really what we want, right? Really what we want, the best thing here is going to be robot that it will like comes in, it shows you where he wants to put the screws in, you agree to the plan, and then the robot will put in all those screws for you, right? You just have this, you just sit there and watch and make sure everything is moving smoothly and correctly and according to plan. And it'll have the knowledge to know if it's putting a screw in the wrong place, then it'll stop, right? It's not going to just keep going automatically. It's going to, oh, no, something's off, I have to re-register, da, da, da. So that would be the best. You can just kind of set it and forget it, give like 30 minutes, let the robot put the screws, whatever, 45 minutes, put all the screws in, then you can come in and do the case. Because actually putting the screws is just part one. You still have the osteotomies, you have the decompression, you have the correction to do, you got to bend the rod, so many things you got to do here. The problem is like you can see from the videos, illustrative videos I showed, if you're doing osteotome, mallet, Lexel, gear shift, sound, tap, sound, screw. It's exhausting. Every single screw you got to put that in. By the time you have the screws in, you're like ready to go to bed. So and then your wrist and the surgeon longevity. There's all these things you got to factor in here. So it's nice, if we can get to that level. It's not ready yet. It's not quite there yet. Now, maybe this is a topic for another talk, but we can talk about why there's a lot of why these robots came out and how the first generation of them were so not ready for prime time and what happened. And we can talk about that. That's probably another talk we can do. But they're now pretty much, there's some surgeons who regularly use these and they're pretty comfortable using it and they're having good results. And I think we finally reached that stage now. Will it be gold standard where we're like, you have to use a robot for placing screws, and if you don't, that's malpractice? That's probably about 20 years away. I don't think we're anywhere close to that. But this technology will get better. That's guaranteed. It's just not going to go away. The technology will get better, and this will eventually reach that kind of that golden spot for this technology to be at. But right now, it's still not quite 100%. Now, another thing that was nice, I was just talking about this before, was kind of the angles, right? And just this little angle here, just if you put the screw in at 14 versus 26 degrees, right? Makes a big difference in how the rod is going to look. Okay, it's a little tiny little thing like that, right? Means such a difference in your rod, and uh, this can be super annoying. And that's one of the things I like the most about the robot, by the way, is the rod because it makes it much easier to put that rod in. Um, if you're a surgeon that operates with residents or trainees or ACPs, um, you have to be very careful. It's not, certain things that are automatic for you, they're not that you've developed with years and years of experience in cases, they have not developed yet. So screw cadence, just having the heads of the screws line up, well, it's at this point, I don't even think about it. It's like automatic, right? Um, and if you're working with a trainee, they haven't thought about that yet. So if just one screw that's the head is off, oh my God, it becomes so painful to put that rod in, and you have to futz around, and I don't like putting like an extender. It's very painful. So this is nice. Now, what has happened though, right? What has happened though, and this is not a good thing. And I talked about this a little bit over X, and we kind of let me just fast forward this a little bit. What has happened though, and is that uh, our training now is rapidly defaulting to robots. And what's happening is that we have trainees. If you have a fellow, for example, right? The attending doesn't want to give you autonomy as a fellow, right? They want you to learn. They want you to learn on your own. They want you to do stuff on your own and kind of get that experience because you got to make a. I hate to say it this way, but you got to make some mistakes sometime. You got to, it's not always perfect. You have to place that gear shift and then feel it, and you're like, oh, this doesn't feel right. Something's not right, and figure that out yourself. What you did wrong. I was too lateral. That's usually the case, for example, right? Or you're too medial. Your trajectory's totally off, right? And you're like, what did I do wrong, right? And you kind of learn that, let's say, and then the angles of the pedicles change depending on what level you're at, right? So like at T12, you're going to go very straight. At S1, you're going to be very lateral to medial, right? And that takes time. It takes years and years and years of practice to really get that down. But with a robot, you kind of don't develop that skill because everything is shown to you and it kind of does that for you, right? So when you're in the controlled setting of a fellowship, you graduate, you get out in the real world. The vast majority of hospitals don't have this technology, right? And they have a fluoro, and they think that's like, oh, isn't that a robot? Isn't that? And if you're not comfortable doing freehand, if you're not comfortable putting screws fluoro, you're gonna be a very limited surgeon. You can't operate anywhere really. How you gonna take call in certain places if the robot's not there? What are you gonna do? You become a very, very limited surgeon. That's not a good thing to be. I'm seeing a lot more of these trainees coming out who are completely dependent on navigation and robotics. They cannot do a case if they don't have nav. They can't do a case if they don't have a robot. That's a very bad place for us as a field. And this has to change. This is more of a. I think of this as like a tool. This is like before this stuff came around, you would just do this freehand, right? And when nav came around, it was great. And you can use it, but at the end of the day, nav still has its issues. Um, you still have to be able to put these screws in. If the nav goes down or is inaccurate or something happens, you should have to be able to finish that case. Um, but it's nice. It's definitely a nice technology to have. When things go well, it goes great. It's super awesome. And what's really nice about it, and as well, is that um, you know, I used to be very concerned about how these screws were going to look and this and that, but it's actually pretty accurate. When things are going well, um, it's nice. And you're all like different. I'm showing you some examples. I haven't done these myself. I got some of these slides from one of my partners. But he was doing some really cool stuff. Like I was watching him in the OR and I was like, wow, I've never seen anything like that before, Not the MSD pressure. I like this though. A facet decortication. This was pretty cool, I thought. He used a reamer to kind of like core out the facets and get a little bit of a all-night fusion, which was pretty cool. But this is nice. Like he used this to drop in a tube. So they did a lateral, right? And he wanted to get a little bit more of a foraminal decompression here. So he dropped in a tube on that side using the robot to kind of open that level up a little bit more, which is nice. Now, there are a lot of downsides to this, and it's mostly most of it I circled here. This is the problem. It's just the trays. My goodness, it takes so long to get these cases set up. Um, unless you are at a high volume center with many surgeons who use this all the time, right? It's so hard to get this time down. It's so hard to get this time down. It adds so much time to your case. If you're using a CT, like an Aero CT or O-arm, adding even more time to the case, it's very painful. It's very painful. You have to be patient. You have to be patient. You have to be patient with the team. You don't always get the people who know how to use this or know how to set it up because the tendency is to have like one tech in the room, just one person who knows how to do it, right? There's one tech who knows how to set it up, and if they're not there or something happens, nobody knows what's going on, so it becomes very, very difficult, very frustrating, very challenging. So if you have a late case, right? You can't use a robot. I mean, sure, if you want to stay until 4 o'clock in the morning, yes, you can do that, but it's gonna be very stressful for you. You don't want that. Um, things missing from the trays. That was something I thought was frustrating. Like, we don't have this one little thing that it's super critical and important to get this case going. So what do you want to do? And it's like, oh my God, and you can't do anything more. You're stuck. That stuff happened all the time. It's crazy. It's crazy to think that that's the case, but it happens. You got to think about this stuff. Do we wait for them to find, we found it, but it's not sterile, so we got to reprocess it. That takes 45 minutes to an hour, right? Do you want to just keep going or do you want to wait? I mean, you have like two more cases going. There's always something. So it's very these are all things you got to kind of take into account. Now, where is this going? I kind of alluded to this before. This is getting to a point where it's becoming autonomous, where you can just kind of set it and forget it. Eventually, uh, I see this also being able to do like a laminectomy, where it will use, let's say, an ultrasonic, there's something like the Misonics, for example, the bone scalpel or the broad knife, striker broad knife, where it can do troughs for you and it detects when it hits dura or soft tissue underneath, and it'll stop and it'll just keep moving, rosterally and caudally, and it'll get you the laminectomy that you need, and that'll be kind of like the ultimate. It's far away a ways from that. It's not nowhere close to that, but well, it'll get there. It'll get there. It just takes time. Now, this was a paper that we wrote a while ago looking at the validity of this, and it's pretty accurate. But the problem with these papers are that the vast majority, these are all retrospective studies, they're all conflict of interest, and there is a strong, strong therapeutic illusion and confirmation bias with these, as with almost every paper in spinal surgery. But with these, it's tough to know. You don't really see too many, all you see are good papers, right? Every single paper, look, it kind of, I don't know if you can read this here, 100%, 99% accuracy, 97 accuracy, right? All of them are good papers, right? And there's this propensity to want to have this technology advance, get better, so we want to publish good papers, right? But you should be very skeptical of something where it's only good papers and no bad papers, right? Because oftentimes we tend not to want to publish that. Because imagine you have all these authors here, right? Imagine you're doing a paper on robotics and you got a bad result, right? Well, look at how many papers are here that have been published and all of them show a positive result. What are they going to say about your paper? They're going to say that there was something wrong with you. So people tend not to publish that stuff. And as a result, we don't get like fair and balanced data. It's all off to one side. And then you hear of recent reports of the Globus robot being inaccurate and it's being investigated by the FDA. And then you're like, oh, well, look at this. How can that be? Look at all the papers that were written that are positive. It's a complicated situation. Now, we've also got it in, I just want to throw a little bit about this with the augmented reality. This is just another version of navigation, basically, where instead of looking at a screen, you're looking at the patient. There's a screen basically on your face that allows you to see this. This has its uses. It can be nice for certain cases. Interestingly enough, I found that the navigation is more accurate with this than using a spinous process clamp and a stereotactic array or using an iliac hip pin, which I thought was interesting. I don't know, for some reason the augmetic system is more accurate. But it's nice. I don't want to dwell too much on this. I mean, this technology is still developing. It's catching on slowly, but it definitely has its uses. Um, I don't know. What do you think, Alex? Do you use this at all? The augmented reality?
No, not with these beautiful screens. I have an AR system, but it's not that highly developed. We are just waiting for all these FDA approval, and
Yeah.
in Europe, the a lot more difficult European EMEA approval, which takes always additional studies and additional 2 years. So you guys are very lucky to have a faster release of new technology into your daily practice. For example, when there's a new system, I mean, I'm not in the European Union, I'm in Switzerland, which is definitely allowed to look to the US and to introduce implants into the Swiss system that only have the FDA approval, not the European approval. But
Right.
it always takes time. And I know these systems from congresses, from courses. There are similar systems here in development. Small companies are doing really good because this technology and the software is available everywhere. It's not so many patents are pending on them. So gaming industries goes into augmented reality, and this wonderful rendering of the bony surface, even if the images are low quality, like you have shown us. Yeah. So the software from Medtronic, I think it was a Mazor system, allows us to have the feeling that we see something very beautifully, although the raw data is very bad. And this
Yes.
is really a great benefit. And the software companies have managed to pick up graphic specialists from the gaming industry, put them into their R&D stuff, and they build up a really good software. And the processors, the CPUs, are so fast today. Like
Mm.
the first Spinal navigation system I've used 20 years ago, it was grab out and have a cup of coffee and tea.
Yes, yes, I remember. I remember the original. You had to have a CD. Oh my God, it was so painful. That was one of the nicest things is just being able to. Alex, are you still there by any chance? Oh, I think you froze, unfortunately. Okay. All right. I remember the original, you get a spin, you had to burn that images on a CD, and then you had to put that CD, upload it to the machine, then confirm it. It took forever. It was so painful. Now just with uploading it directly was a real benefit. I'm just looking through the chat a little bit. I have to say, Alyssa Hoffman, I agree with you 100%. Um, uh, basically, you know, the robot is a tool. It's like a mallet, you know. It has to be operated by someone who can understand exactly the nuances and figure out what's going on. It's once you've mastered freehand, then comes navigation, then comes robot. Maybe a little bit when you're first learning, should you use those tools just so you get a feel of the anatomy. And that's really what it defaults down to, be comfortable with the anatomy. Because if you don't get comfortable with the anatomy, you're going to be in bad shape. You're never going to get comfortable if you're dependent on the robot or navigation. So it's very, very key. Um, I apologize, everybody, but unfortunately, I have to run to have to cut this a little bit early. But I thank you all for coming tonight. If you have any more questions, please, either let me know on X. We can have a nice open discussion about it, or just email me directly. Um, but I hope you all thought this was a useful talk. I thank you all for coming, and I hope you all come to the next week's Virtual Global Spine. I hope you all have a great holiday, and thank you very much, Alex, and everyone for attending tonight.
Thank you very much. Sorry for my connection.